Dear panelists, ladies and gentlemen, my PhD takes a translational approach to the prevention of diabetes after acute pancreatitis and in pre-diabetic individuals. I'm Olga Zahariev, a UK-trained dietitian working at the Pancreatic Division, at the Division of Pancreatic Diseases, and my vision is a world where preventable diabetes is prevented, and my mission is to shift health policy towards prevention and to educate patients. I use various methodologies to explore my topic of interest. The first project aims to identify patients at risk of developing diabetes. The second one investigates the effect of lifestyle interventions on preventing diabetes, but this was in the general population. And the last one is an interventional study in acute pancreatitis patients, which explores the effect of dietary intervention on pancreatitis recurrence and endocrine insufficiency. So the first project is identifying patients at risk of developing diabetes after acute pancreatitis. Diabetes is the 9th leading cause of death globally, and it has a huge economic burden on society. Approximately 23% of the patients who have acute pancreatitis go on to develop diabetes within the first 5 years, whereas the incidence of abnormal glucose tolerance can be as high as 40%. However, currently there is a gap in knowledge regarding diabetes formation after acute pancreatitis and patient management. Therefore, as a first step, I would identify patients at risk of developing diabetes. The population is patients with acute pancreatitis without diabetes at discharge. We will compare various biomarkers to their absence, such as severity, etiology, necrosis, and obesity. The outcome that we are studying is new onset diabetes and new onset dysglycemia. We believe that diabetes mellitus develops significantly more frequently after acute pancreatitis that was severe, necrotic, or caused by hypertriglyceridemia. Systematic search has identified nearly 12,600 records, and after full-text selection, we have been left with 64 studies. So far, we have results for severity, and most of the studies included, of the 19 articles, have used the revised Atlanta criteria, which classifies severity into mild, moderate, and severe, based on organ failure and local complications. In the near future, we will also have data regarding etiology and necrosis. For the first plot, you see the odds of developing diabetes in severe disease compared to non-severe disease. The overall effect shows that severe pancreatitis is associated with a 2.5 times higher risk of developing diabetes. However, you can notice that statistical heterogeneity has been quite large. The subgroup analysis for mean follow-up time actually accounts for some of this heterogeneity. So on the top, you can see the smallest subgroup with the shortest follow-up of 3 months, and at the bottom, you can see the follow-up subgroup analysis for 4 to 5 years. And you can see the trend, which implies that the closer the follow-up time to the acute pancreatitis onset, the larger the difference between the groups for developing diabetes. On this slide, you see results for the same outcome, diabetes. However, now we are comparing severe and moderate to mild disease progression. You can notice that the odds ratio is smaller here, which possibly suggests that the initial difference between the groups is mostly accounted for by severe disease progression. On this slide, you can see results for dysglycemia or abnormal glucose tolerance. This one includes not just diabetes, but pre-diabetes as well. First, we compare severe to non-severe disease progression. And the overall effect shows that severe pancreatitis is associated with a 3 times higher risk of developing dysglycemia compared to moderate or mild. This is the biggest odds ratio so far, and this would imply that the difference between the groups is even larger when it comes to pre-diabetes. On this slide, you see again dysglycemia as an outcome. However, now we compare severe and moderate to mild disease progression. You can notice here that the odds ratio is the largest, meaning that having severe or moderate pancreatitis is associated with a 6 times higher risk of developing dysglycemia compared to mild disease. The strengths of the study included that we had a robust scientific methodology, and we have used some large sample sizes. However, the meta-analysis was limited by the fact that the outcome definitions varied between the studies and that they have checked the outcome at different time points. We attempted to account for this by the subgroup analysis. Research so far has established that there is a continuous deterioration of carbohydrate metabolism. Moreover, there is a drastic deterioration in abnormal glucose tolerance in the first year, and it further decreases after the 5-year period. You can see at the bottom of the slide the summary of the odds ratios of our study. And our study concludes that in the early phase, abnormal glucose tolerance development is strongly associated with pancreatitis severity, and that the association is even stronger with prediabetes than diabetes. The implication for practice would be that all patients should be followed up and monitored for diabetes and prediabetes after having acute pancreatitis. Moreover, in the early phase, the more severe the disease, the more frequent the control visits should be. Future research should focus on exploring preventative interventions following acute pancreatitis. The second project that I am involved in is an interventional study. This one is exploring the effect of dietary intervention on pancreatitis recurrence, chronic pancreatitis progression, and endocrine insufficiency. As a dietitian, I was given the task of developing the dietary intervention because this study is focusing on the diet. So when patients have an acute pancreatitis episode, they go home, and for 2 years we will be following them up. The intervention will have 2 arms. One of them will be instructed to consume 15% dietary fat, and the other one will have 30% fat content. This is the instruction, but they need help to be able to actually keep to this diet. So in the past 2 weeks, we have been developing weekly meal plans, recipe books, and other patient education materials to help the patients to keep and adhere to the intervention. The final project is about investigating the effect of diet and exercise interventions on preventing or delaying diabetes. We have established that diabetes has a huge health and economic burden on society. Moreover, its prevalence is increasing. It's 9.3%, which has doubled since 1990. Its development takes years, and it is preceded by prediabetes. Also, lifestyle interventions have been found to actually reverse prediabetes. But currently, there is a lack of guidance on the most effective lifestyle intervention. Our study aims to fill this gap and give advice on what would be the most effective intervention. The population is prediabetic or insulin-resistant adults, and we will explore various diet and exercise interventions. The outcome of interest is new onset diabetes. We believe that there is going to be a difference between the different diet, exercise, or lifestyle interventions. The importance of the study is that it would provide evidence-based guideline, and nowadays many people feel that they become nutritional experts just after having read a couple of articles online. But we know that that can be dangerous. Therefore, providing evidence-based guideline would be the safest treatment for our patients. Preliminary research has been carried out, and we have established that there will be enough data to do this research on. However, because I have been focusing on the first 2 projects, there has been no time to delve into this topic as well. So I would like to close my presentation. My PhD will identify people at risk of developing diabetes after acute pancreatitis. It will determine if dietary fat content affects pancreatitis recurrence and progression to chronic pancreatitis and endocrine insufficiency. Lastly, it will enhance the understanding of the efficacy of various lifestyle interventions in preventing diabetes. I would like to close the presentation with a quote from Thomas Edison. The doctor of the future will interest his patients in the care of the human frame, diet, and in the cause and prevention of disease. Thank you for your attention. Feel free to ask any questions.
Regarding your first project, as I saw on your plot, I think the third one, there were outliers, one outlier. What can be the reason for that?
So you can notice that UAN 2017 is quite different to the others. While we made sure that all the studies excluded pre-existing diabetes mellitus, not all of the studies were able to exclude pre-existing pre-diabetes. So UAN actually did exclude these patients, so it would be a much more stringent data. And on this last slide, there are also a couple of outliers. For example, if you see Trago on the top, 2015, the odds ratio for it is 51. Now, it's important to bear in mind that this is the shortest follow-up of 30 days. Now, this could actually mean that this is what we are seeing is just a transient abnormal glucose tolerance, especially the fact that it's not just diabetes, but glucose tolerance, it would be definitely an explanation for this outlier.
I wanted to ask, briefly reading through your search key, that would you like to add vegan, vegetarian, ketogenic, and so on diets regarding the outcomes?
You mean this is for the second meta-analysis,
yes.
right? Because we have not, so we only included diet. Whenever you are asking for vegan or Mediterranean, at any point it would include diet in the title as well. But we will not be excluding them, and this is what we are looking at. So far there has been meta-analysis in this topic, but they have not done the subgroup analysis for the different diets. So we are looking at Mediterranean, low carbohydrate, low fat. We are trying to make this subgroup, but this is actually proving the hardest part. So yes, we will have these groups. Thank you.
My question maybe is too soon to ask, but after a mild disease, what should this frequency mean for screening?
I would say in our center, for example, we have a control at 1 month, but probably at around 3 months would be also good to check on their glucose, because that would give enough time for the differences to set in, and approximately every 3 months would be beneficial.
So this is about your second, the trial.
Yes.
Traditionally, dietary studies always suffer from a huge heterogeneity and risk of bias when it comes to control groups. And there are pros and cons of having a multi-center trial. Why multi-center trial? What kind of advantage will multi-center study have that you cannot analyze with a unicenter study? Because in this way, you are not introducing even more heterogeneity into a dietary study.
Good point. I would say it would be more like a real-life intervention, because what we are looking at is we might come up with an intervention, but then we're going to say this to the doctors, like, this was a good way to do it. Go into your practice, try and do it. So if there are more centers, we will get a more realistic result. It will obviously reduce the effect from that perspective. We could make much more stringent data if it was only one center. It has been also discussed to have it in several countries. From a dietary perspective, I have restraints regarding the fact that people in Israel would be having the same weekly meal plans that we have created over here. So yes, we are still looking at it, but I think PAGE could be something to include maybe in the future.
3 months seems to be a bit frequent for me. That was the only thing I wanted to add. So for the severe ones, should be more frequent than 3 months.
Yes, screening. Yes. So the idea is that if someone has a severe disease, probably in the first year we see that there is a very big difference. So having them more frequently than 3 months, definitely. Moderate, a little bit less frequent. And when it comes to mild, I would say it's nothing set in stone. We don't have actual data to say this, but I would presume that 3 months for the first year, and then maybe 6 months, and then going into 1 year range.
We see the impairment of both endocrine and exocrine pancreatic function after acute pancreatitis, but afterwards the exocrine function not so rarely improves. What about the endocrine function? Can it improve later on? Do you have any data about that?
So I would say it's, I believe it could improve if the patients are making changes. So if we have someone who is leading a lifestyle where there is a lot of room for improvement, it could improve. But if they had, for example, a disease of the pancreas, so they had a type of pancreatitis where it got damaged very severely, so we have like physical problem with it from now on, it will have obviously less chance of improving the glycemic indexes. However, we don't have data actually on diabetes prevention strategies so far, so that will be something we will be looking at, and hopefully we'll be able to answer it soon.
Very good. My second question is that how many bottles of wine did you already collect today?
Oh, none. Sorry, none. One? I have one.
Oh, only one? Okay. Congratulations for your activity, that's all.
Thank you.